If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. In today's episode, we'll go through the recommendations by the European Association of Urology, or EAU, on male hypogonadism, focusing on what is relevant in primary care only. The link to the guideline is in the episode description. In today's episode, we'll focus on late-onset hypogonadism, its presentation, interpretation of test results, and a brief overview of the general management. If you haven't already, I recommend that you check the previous episode where we cover the definition, classification, causes, and clinical associations of male hypogonadism. The link to it is also in the episode description. Right, let's jump into it. The diagnosis of functional hypogonadism is based on the exclusion of an organic or structural cause. The main causes suggested for functional hypogonadism are obesity, comorbidities, and aging, with the first two accounting for the majority of cases. This is because the evidence shows that chronic comorbidities can interfere with the hypothalamic pituitary testicular axis, leading to functional hypogonadism. In fact, the role of aging in hypogonadism up to the age of 80 years seems relatively small. Late-onset hypogonadism is a term that is used frequently incorrectly to describe the declining testosterone production due to aging, or simply the detection of hypogonadism in adults. However, the truth is that late-onset hypogonadism is in fact a broad clinical entity, including adult-onset forms, which can have an organic or functional origin and can be primary or secondary. Late-onset hypogonadism is frequently diagnosed in the absence of an identifiable organic cause, and it becomes more prevalent with age. By definition, late-onset hypogonadism must comprise both persistent, specific symptoms and biochemical evidence of testosterone deficiency. The mainstay of late-onset hypogonadism diagnosis includes signs and symptoms consistent with hypogonadism, coupled with biochemical evidence of low morning total testosterone levels on 2 or more occasions measured in fasting conditions. In the history, we will take note of specific symptoms associated with hypogonadism. Symptoms can be grouped into 3 main categories: sexual, physical, and psychological. Examples of sexual symptoms include reduced libido, erectile dysfunction, fewer spontaneous erections, less frequent sexual activity or masturbation, and delayed ejaculation. Examples of physical symptoms are reduced ability to perform vigorous activities, difficulty walking more than 1 kilometer, hot flashes, lower energy levels, and reduced physical strength. And finally, examples of psychological symptoms include low mood, loss of motivation, general fatigue, difficulty concentrating, and sleep disturbances. As we can see, some of the symptoms are non-specific and need to be taken in context with the clinical and biochemical state. Also, headache and/or visual disturbances may indicate a pituitary-related disorder. As part of the physical examination, BMI and the measurement of waist circumference are strongly recommended for everyone. This is because of the strong association between hypogonadism and obesity. Testicular and penile size, as well as the presence of sexual secondary characteristics, can also provide useful information regarding the overall androgen status. Finally, digital rectal examination should be performed before testosterone therapy or to support suspicion of hypogonadism, where we would normally expect a reduced prostatic volume. How should we investigate male hypogonadism? The main initial test is obviously serum testosterone. Testosterone levels are produced in a circadian variation, which may persist in aging men. Testosterone levels are also potentially influenced by food intake. Therefore, serum total testosterone should be measured in fasting conditions and in the morning, usually between 7 and 11 o'clock. A confirmatory measurement should always be undertaken in the case of an abnormal value. a testosterone of 12 nanomole per liter should be considered as a possible threshold for starting testosterone therapy in the presence of typical symptoms. If abnormal total testosterone levels are found, we should check LH and FSH along with prolactin in order to investigate possible underlying conditions and exclude possible organic causes. Let's look at these tests individually. FSH and LH levels can help differentiate between the diagnosis of primary or secondary hypogonadism. In primary hypogonadism, testosterone will be low and gonadotropins will be high. In secondary hypogonadism, testosterone will be low and gonadotropins will be low or inappropriately normal. Due to its negative influence on libido, prolactin should also be considered as a first-line screening test in patients with reduced sexual desire. In addition, contrast-enhanced pituitary MRI scanning, as well as other pituitary hormone tests, may be required in the presence of specific symptoms such as visual disturbances, headache, and when hyperprolactinemia is confirmed. We also need to be aware that total testosterone values may change as a function of circulating sex hormone binding globulin levels. Let's now look at the factors that may affect sex hormone binding globulin concentrations. Common conditions that increase sex hormone binding globulin include certain drugs like anticonvulsants, estrogens, and thyroid hormone, hyperthyroidism, liver disease, aging, smoking, and HIV or AIDS. A high sex hormone binding globulin can lead to lower free testosterone, even if total testosterone looks normal. Conversely, and although not connected to hypogonadism, conditions that decrease sex hormone binding globulin levels include drugs like glucocorticoids, testosterone or anabolic steroids, hypothyroidism, obesity, Cushing's syndrome, insulin resistance as seen in metabolic syndrome and type 2 diabetes, and non-alcoholic fatty liver disease and related conditions. A low sex hormone binding globulin can lead to higher free testosterone, and it may be a sign of underlying metabolic issues. Therefore, understanding sex hormone binding globulin levels is important because it helps us interpret total testosterone results more accurately, especially in men with metabolic or endocrine disorders. In clinical conditions that may affect sex hormone binding globulin levels, checking free testosterone can be considered. However, there is currently no consensus on threshold values, so these remain an area of uncertainty. Having considered all of this, let's look at a step-by-step approach to evaluating male hypogonadism. Firstly, we will start with a clinical suspicion. So if a man presents with symptoms like fatigue, low libido, erectile dysfunction, or reduced muscle mass, we should consider hypogonadism. As the initial blood test for hypogonadism, we will check total testosterone, ideally in a morning fasting sample between 7 and 11 o'clock. If the result is low or borderline, we will repeat the testosterone to confirm it and add LH, FSH, prolactin, and possibly sex hormone binding globulin and free testosterone, depending on our clinical judgment. However, if the testosterone result is normal, then hypogonadism is unlikely. If symptoms are strong and highly suspicious, we could consider repeating the test and checking other tests, including sex hormone binding globulin and free testosterone. If the repeat sample confirms low testosterone, then we will need to differentiate the type of hypogonadism by looking at the gonadotropins. If testosterone is low and LH, FSH are high, we are looking at primary hypogonadism, which in principle will be a testicular problem. However, if testosterone is low and LH and FSH is low or normal, then we're looking at secondary hypogonadism, which would refer to a hypothalamic or pituitary problem. Depending on the type, we will take the following steps. For primary hypogonadism, we can consider karyotyping, like for example Klinefelter syndrome, and we will refer to urology to fully assess testicular function. For secondary hypogonadism, we should consider referral and further imaging such as a pituitary MRI scan to exclude pituitary tumors, And we should also assess for chronic illnesses, obesity, metabolic disorders, and medications that could interfere with the hypothalamic pituitary axis. Additionally, if sex hormone binding globulin is abnormal, for example in obesity, aging, or liver disease, we could also consider, if not already done, checking free testosterone, as they may give a better diagnostic clarity. In terms of management, I will not say much because the treatment will be guided by secondary care. I will just mention that generally patients with symptomatic hypogonadism, usually with a total testosterone level of less than 12 nanomole per liter, without specific contraindications, are given testosterone therapy. Absolute contraindications for testosterone therapy are untreated breast and prostate cancer, and conditions such as cardiovascular events, a hematocrit of 54% or higher, and poorly controlled congestive heart failure. There are a range of relative contraindications and cautions which will need to be considered by secondary care. Finally, we will need to check the patient's fertility needs. If a patient wants to maintain fertility, we should avoid testosterone therapy in secondary hypogonadism and consider alternatives like gonadotropins instead. This is because testosterone therapy suppresses gonadotropin and endogenous testosterone secretion, as well as spermatogenesis, reducing fertility as a result. So that is it, a review of late-onset hypogonadism, its clinical presentation, interpretation of test results, and a brief overview of the management. Remember to check the previous episode where we cover the definition, classification, causes, and clinical associations of male hypogonadism. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.